I am Dr. PLN Kapardi, interventional cardiologist of Care Hospitals, Banjaras, Hyderabad. Today I am going to present a case in box of RCA Calcific instant stenosis angioplasty. The clinical history is as follows: a 68 years old gentleman having risk factors of the hypertension and diabetes, and presented with a rest angina, and he has inducible ischemia in TMT, and his LV function is good, and angiogram is showing two vessel disease in 2020, and he underwent angioplasty and less to the LAD and right conrod in 2020, and presently he had a ISR of right conrod, that is an index case for angioplasty. And this is the angiogram which revealed a proximal ISR of almost 85% of the lesion with a TIMI 2 flows. And as a part of intervention, as a left side stent was patent, we pre-dilated with 2 into 15 millimeters balloon in the ISR to facilitate the cutting balloon or scoring balloon. And then this is the result. Still the residual lesion is present, so we further dilated with 2.5 to 10 millimeters scoring balloon, and then we dilated the lesion with a 3 into 10 non-compliant balloon. And after debulking, we want to examine by means of intravascular ultrasound in view of still residual lesion present and what is the mechanism of non-yielding lesion. And this is the static image of intravascular ultrasound with needs, which was showing almost napkin ring calcium both inside and outside the stent struts almost 360 degrees with low cholesterol burden index, that is 217. Usual less than 400 means low cholesterol burden index, more than 400 means high cholesterol burden index. And this is after intravascular ultrasound. These are the images which revealed there is a non-yielding lesion. So we want to debulk the calcium, as it is almost 360 degrees calcium. We want to do intravascular ultrasound, which is as per algorithm aggressive debulking, calcium debulking device. And we have taken almost 3 into 12 millimeters IVL balloon, and we delivered almost 80 pulses in 8 cycles, and maximally distal portion of the lesion, which is showing the napkin ring, almost 5 cycles we delivered distal portion of the lesion, and 3 cycles in the proximal portion of the lesion. And then the post IVL, so it is showing almost the non-yielding lesion yielded, and now we can show the gain of the luminal area inside the stent. And then subsequently we did high pressure dilatation with 3.5 into 12 millimeters NC balloon. And then intravascular ultrasound, it is after high pressure dilatation with NC as well as the OPN high pressure almost to the 28 to 30 atmospheres we did, and it was revealed almost the calcium was fractured, and then previously the catheter hugging napkin ring, now the luminal gain almost to the tune of the 7.8 square millimeters, very nicely it was dilated with a maximal luminal gain post IVL as well as high pressure dilatation. And then subsequently we treated the lesion with a paclitaxel eluting drug eluting balloon 3.5 into 15 millimeters. Almost these were delivered with 3 cycles. Actually we delivered that balloon, the drug. So the first cycle it delivers 60%, and second cycle 30%, and then remaining third cycle 10% of the drug was delivered, each almost to the tune of 30 to 45 seconds we have to deliver. And this is the final result, which is showing almost maximal luminal gain with TIMI 3 flows with a very good final result. So take home message here: this is a complex calcific ISR lesion of the right coronary artery. Usually the calcific ISR poses the difficulties in view of undilatable and uncrossable lesion. In the present case, this ISR lesion is undilatable and non-yielding in spite of the angiosculpt as well as the cutting balloon also we used, which I did not show in the slide. And IVUS, what is the mechanism of non-yielding? Once we have shown, it is the cause of ISR is undilatability. Undilatability is undersized stent we deployed, and if we revise it, it is almost 3.5 is the vessel size, but we deployed 2.75 millimeters stent, which is grossly underexpanded under mala post. So mechanical causes for this instant restenosis with calcification. And in spite of the all the modifying devices like sculpted balloon, NC balloon, as well as the cutting balloon, still the residual lesion is present because of the calcium, which was unmasked, or the mechanism was revealed by means of IVUS with NIRS. And then the most effective modifying device, that is intravascular lithotripsy, which modified the calcium both inside as well as outside the stent struts with maximal luminal gain, and subsequently post-stent dilated with NC as well as OPN balloon so aggressively, which ultimately break the Napkin's calcium of 360 degrees with a maximum luminal gain of 7.8 square millimeters. And subsequently, after adequate lesion preparation, we did, as per the guidelines, these paclitaxel eluting balloon and delivered the drug with ultimately good result. And we have to evade the long-term patency rates also. We counsel the patient for follow-up angiogram after 1 year. Thank you.